start whenever you want, but I wanted to make sure I get the audio settings correct.
That is fine. I just want to make sure that my question box is big enough to see. Let's see. What can you tell? Oh, they're already going on.
Okay. So it is recording.
It's recording? Does that mean the broadcast has started, or?
No, when you're ready, you just
I
have
can
to
do that.
hit, yep, you just have to hit start broadcast.
Okay. Well, I think we're, the first.
I'm sorry, I'm having a hard time seeing the question that just got posted.
You got to have to kind of open up the box using the cursor. There's one that came up so far already, which is one I think we can kind of take on.
You can also resize those boxes so you see it's kind of in a column format. You can click and drag that so that you can see more of the actual question.
Mm-hmm. Okay.
Can you see that?
Mm-hmm.
All right, well, we got
18 people so far, and I'll stay on here in case there's any problem, but I'm just going to mute myself, so if you guys need anything, let me know.
Well, the one question I do have before we start is, are we going to do any, are we going to let people speak? Are we going to open up their hands? How do we do that?
Yes, so there is people can raise their hands, and I believe, click to lower, let's see.
So we would want to tell people that they can do that.
Yes, and they can type in their questions in the question box. It's different than chat. Chat is only between you two or me and the presenter.
Like, I'm trying to get this.
Yeah, and I got that. What I'm wondering is, so we should instruct folks to raise their hand if they would like to speak. And I can do that by going to the attendee list. And how do I actually, I would unmute them?
Yes, so you can see the green thing with the red line through it right now. You would just click on that.
So is it easy
but they
enough
can
to tell people?
They can do questions the entire time, and if you just want to call on them, then you would unmute them.
Yeah.
Okay. Thanks.
All right. Well, I'm going to go ahead and start, and we'll see how this goes.
Okay.
The broadcast is now starting. All attendees are in listen-only mode.
So good afternoon to folks on the East Coast. Good morning to folks roughly west of the Mississippi. This is Eric Bruns. I co-direct the National Wraparound Initiative with Janet Walker from Portland State University. And today we have scheduled a very special NWI event. As you know, or some of you probably know, we do webinars periodically about once every 2 or 3 months here at the National Wraparound Initiative. And today we're trying something a little bit different. As long as we need, up to 90 minutes to have a National Wraparound Initiative open house. We've never done this before, and as I'll explain in a minute, we do have some mitigating circumstances to our office hours today that are unfortunate. But we are going to, in fact, host our first ever NWI office hours today. On the line with me is Michelle Zabel, who is the director of the Institute for Innovation and Implementation at the University of Maryland School of Social Work. Do you want to say hello, Michelle?
I was trying to decide if I should say good morning or afternoon. So good morning and afternoon to everyone on the call.
You can say, I'll say good afternoon to you, and you can say good morning to me.
That's right.
So so Eric here is in Seattle. And what we're doing today is something that kind of reflects a modest step in a new direction that the National Wraparound Initiative is going, which is to move from being primarily a kind of resource for online materials and accountability tools to more active direct provider of implementation support to the field of children's services and communities and states and provider organizations that are implementing the wraparound process. So we are, so the NWI as part of this is kind of looking for opportunities to provide this more direct support to those entities that might be implementing Wraparound. And so what we're going to do today is, what we planned to do today was to have this office hours during which time any and all comers could come on to the webinar, and using our interactive pane that you should have from the GoToMeeting here, type in your questions, or you can also raise your hand and we can call on you and unmute you to ask your questions directly. In the categories of wraparound practice, training, coaching, and supervision, wraparound research and accountability, and also program and system support and financing for local, state level wraparound implementation. Unfortunately, we were intending to have 4 presenters today from the NWI, including Marlene Matarese, who's the Director of Training at the Institute for Innovation and Implementation, and Joanne Hust, who is an expert in parent support and family peer-to-peer support in Wraparound. But both Marlene and Joanne have had family emergencies in the last 24 hours and are unable to attend today. So what we do have is myself, Eric, who is going to take on the wraparound research accountability questions, and Michelle, who is going to take on the program and system support and financing questions. But we will have a little bit of a lack of in-depth expertise around the practice level implementation of wraparound for facilitators and family peer-to-peer support partners. We will do our best to note your questions in those areas, and we'll do our best to answer them. But we will, unfortunately, have to take those questions and potentially have them delivered to you offline, because Joanne and Marlene both unexpectedly were unable to attend today. But we're going to do our best. So Michelle, anything else you want to add about your expertise and the types of questions that you're prepared to field today?
No, I feel like you covered it. I mean, I do feel like there's probably experts on the phone as well, and so I think using this type of interactive tool allows people to also contribute. And so although I think, we're going to do our best, Eric, to answer people's questions or direct them to the best resources we know about, if others have information that they want to share, I feel like they should contribute that as well.
Absolutely. So I'm going to do my best now. So a few notes about the technology. Right now, everybody is on mute who is attending the webinar. However, there is an icon on your control panel that allows you to raise your hand if you would like to have your question be asked directly through your phone line or your microphone that's connected to your computer. Donna, is that correct, that folks could use either the phone line or the computer to ask questions?
That is correct. If they do use the phone, that's how they should be connected already.
Okay, great. So right now there are no hands raised that I see, but we do have one question that's been typed into the question pane. And we encourage folks to go ahead and to type their questions into the question pane or raise their hand, and we will try to kind of address the questions that we get in order. Once again, today all we're really doing is to answer your questions. We don't have any stock webinar kind of content beyond just really quick encouraging you, if you haven't in the past, to go to our website, which should be in front of you here, nwi.pdx.edu. At the website, you're going to find an extraordinary array of materials and something that was recently innovative by the folks at Portland State, which is a inventory of our resources that is searchable and allows you to find any and all resources anywhere on the website that might relate to a question, like if you want to find memorandums of understanding, you can find examples. If you want to see financing models, you'll see a list of materials on that. Parent partners, practice model, anything that you want to put into a search box, you will be able to retrieve an inventory of the materials that we have to offer. So we encourage you to go there. So let's go ahead and get started. We have two questions. The first one is from Tricia Bassing. And what Tricia asks is, what can you tell us about the validity of using Wraparound with older youth, ages 15 to 21? We are considering adding youth partners in addition to or instead of parent partners for this transitioning age group. Are others doing this? And any thoughts would be appreciated. And what I'm going to do is go ahead and unmute Tricia. To some extent, I'm just trying out the technology here. And Tricia, you are now unmuted. And if you so choose, you could add anything else to your question that you like.
I'm not sure if you can hear me. Can you hear me?
Yeah, we can hear you loud and clear.
Oh, great. I didn't know I was going to be unmuted, so I was eating an apple. No, that's pretty much the question. We're considering adding youth partners to support that age group. We appreciate that WRAP is a family-focused model, and as these older youth are transitioning away from family, maybe some of them also have a very much less traditional definition of family, or maybe feel a little bit more disconnected from family, to work to find, many people to participate in their WRAP and their planning and in their plan. And I guess we just wanted some more information if other people are doing this, incorporating the youth partners, if WRAP works with the older age groups. That's about it.
Absolutely. I'm going to put you back on mute because there's a little bit of a feedback there. Actually, I'm going to unmute you real quick. Where are you from, Tricia?
Alexandria, Virginia.
Ah, my hometown. Or close to it. Yeah. So, so this is a question that's frequently asked in the field as peer support. So a few things from me, and then I'll turn it over to Michelle for some additional ideas. But I think that one thing that's really clear is that peer support of all types is gaining prominence in the behavioral services field, and for good reason. This is a method that's been found to be increasingly effective at achieving outcomes in healthcare as well as behavioral health and mental health. And when you start getting to the transition age, you are pushing to young adulthood, and I think that there is emerging some good research that is showing that peer support for adults with serious mental illness, for example, has been found to be something that can promote positive outcomes. So in general, the peer support field is demonstrating the potential for both cost effectiveness of adding peer support to the array of services in a system, or that a provider can provide as an adjunct to whatever other treatments are being provided. In Wraparound, we have done a little bit of research examining some of the data that we have from the Wraparound Fidelity Index and from some other outcomes databases. And if you want to find an original research article on the topic, you would look for an article by Janet Walker, Mike Pullman, and myself. And what I'll do, Tricia, is send that to you. But for others who might be interested, again, this is an original research article by Walker, Pullman, and Bruns. And it found that, in fact, there are some different dynamics of providing Wraparound to kids with, to young adults that require some modifications to the practice model that promote more autonomy and less emphasis on the team being the locus of decision making, and that the young people are getting better outcomes and perceiving more usefulness of the Wraparound model when there is greater autonomy that's given to the young person, and less of that emphasis that you might see for younger youth on the team being the locus of decision making. And so this is kind of a delicate balance that you have to strike when you are serving youth from oftentimes from 4 to 21 or beyond with Wraparound, is how to provide the kind of supports that might be relevant to the older youth. So towards that point, youth partners have been proposed as being one way to achieve that, as something that would be relevant to that older demographic that you might be serving. One place you might look to for their experiences, and we can, in addition to sending you the article about Wraparound with older youth, I'll send you the contact information for the state of Pennsylvania and the Youth and Family Training Institute. The reason that Pennsylvania would be so relevant is that they have a model that explicitly engages older youth with youth partners in Wraparound, and a full training and supervision approach to bringing up those youth partners, many of which, I think probably all of which, have been system involved in the past and are now providing mentoring and peer support to the youth in the counties that are served by high fidelity wraparound, as they call it. So I think that the short answer is that there are places that are doing this, and we can pull together some other sites that are. Michelle, where else do you know that are using youth partners with young people enrolled in wraparound?
Well, I mean, we see it in a multitude of states, but I'm going to be honest, the state that seems like has the best organized approach and best training and support to their youth is really Pennsylvania. And so I would refer people back to that. And then I did want to put out there that kind of building on Pennsylvania's expertise in this area, Youth Move National this year is engaging with NWI and the Institute and others to really develop a more standardized curricula and support model for implementing peer support. So it is absolutely, it's a cutting edge kind of question, and I just think Pennsylvania deserves a lot of credit for the work they've done in this area, and hopefully this year we can kind of capitalize on that and support a lot of other states. The struggle can really be the type of infrastructure that you need to support the actual peer support partners to do this work, and the type of way you employ them, the way you support them, the way you train. So it's a pretty complex endeavor that I think still, and I've repeated it 3 times, Pennsylvania has done one of the best jobs I've seen. I also wanted to point out, for those who don't know this, that in the most recent SAMHSA and CMS Joint Informational Bulletin, Center for Medicaid and CHIP Services, dated May 7th, and we can send this out as well, that this bulletin really describes the coverage of behavioral health services for children, youth, and young adults with significant mental health conditions that SAMHSA and CMS wants to see occurring in states during the era of healthcare reform. And one of the services is peer support, both parent and youth support services. And so it is a topic area that states need to look at and tackle, because in terms of the federal government's perspective on having a full and robust community service array, the peer support, both parent and youth support services, is right here in a jointly released federal bulletin.
So we can send all of it. What we'll probably do is, since we do have contact information for everyone, we'll put together a kind of summary of the resources that we've referenced for everyone that's on the webinar. But certainly, Tricia will make sure that you get all of the original materials. And Tricia, just an advance warning, I'm going to unmute you again just to ask if you have any other follow-up questions. Otherwise, we can move to the next one.
Nope, that's it. Thank you. Very helpful.
Okay. So the next question that I see here, just going down the line in order, is from Ashley Brockbaca. Hope I'm pronouncing that correctly, from Colorado. How are other states and communities supporting the training of family advocates and wraparound facilitators? Where is the training housed? At an institute, at a university? Who pays for the training? And I think that given that it's both about establishing centers of excellence and local capacity to train and coach, and question about financing embedded in there as well, I'll turn that over to Michelle.
Sure. So, every state has to tackle this a little differently. States who are state-funded and state-implemented versus states who are state-funded and locally implemented, everybody has a bit of a different model for really organizing around this. But I will say that one of the things that we've been committed to with a number of colleagues and partners out there in the nation is to figure out a way to grow state-level capacity to sustain wraparound trainers and coaches in local jurisdictions and or states. And so what we've seen in the last 2 years is really an emerging conversation that states are having about establishing what Eric just mentioned, which are centers of excellence. And sometimes those are housed in universities. Other times they're housed in other kind of entities that are legitimate and have been long-standing partners with state agencies. But the states that I'm seeing who are kind of tackling implementation of wraparound on a statewide level are establishing these training hubs that both do training, technical assistance, research, and evaluation, kind of similar to us, similar to Eric's shop at University of Washington, where Janet is at Portland State, Ohio. Like, I can kind of tick through states that are doing this kind of work. And I apologize in advance. You are in Baltimore with me, so an ambulance just went by. I'm really sorry. But there's one kind of document or webinar that we did a while ago for, I feel like it might have been TAP, but we can dig it up, and I know it's posted online. Oh, I know. It was for the, no, maybe it was TAP. Sorry, guys. So we have a webinar that talks about developing and organizing centers of excellence and training hubs, as well as some companion just briefs on what options there are out there. And I think that'd be another resource that, Eric, you guys could post and send out. The issue of funding institutes such as this, really the best advice I can give is that any kind of institute, whether they're at a university or not, should have multifaceted funding. And so one of the benefits of partnering with a university to implement is that universities are good at writing grants and drawing down dollars and finding match dollars and other things. But your basic options for training dollars are state general funds, block grants, both on the child welfare as well as the mental health substance abuse side. You can additionally bill through Title IV-E and Medicaid for training dollars, which if any of your states intend to do that, please call, because there's a lot of do's and don'ts in doing that kind of billing, a lot of record keeping. There's grants. There's the reorganizing of dollars that are already spent on workforce development in the state and putting them into a pot that then can capitalize on kind of a joint effort. And I think that's about it. So you've got kind of federal dollars drawn down to the state, you've got billing that can happen, you've got state general funds, and you've got just plain old grantsmanship as options. And any one of these centers that gets organized and an effort put forth to really bring capacity at the state level to sustain this should not be focused on only one funding stream. They should, just like any good provider out there, should have a few funding streams coming in to really make this all happen. Eric, do you want to add anything to that? And then I do think we should put the webinar out again, which talks really in depth about what elements of a center of excellence states usually want to see brought up.
Right, and so I think you addressed the question about where and how you finance it really, really well. I think that some of the brass tacks about how the actual training and support is delivered, I put up on my screen the website for the National Wraparound Initiative. Ashley, if you're a member of the NWI, you can click on the members and affiliates section and view a piece of guidance that's been developed by the NWI based on implementation science, research, and best practices in wraparound about what some of our kind of minimum expectations are for training, coaching, and supervising RAP facilitators and other staff. So there's, I think, a pretty good amount of resource out there at this point. The webinar that Michelle is describing will be something we provide access to everyone on the office hours today. This guidance kind of demonstrates that there's 3 phases or kind of expands understanding around the 3 phases of workforce support, or being trained and supported to a level of skillful service delivery. There's initial training, there's being mentored and coached to criteria, and then there's follow-on support via supervision. Regardless of whether you're housing it at a university, in state government, in your provider organization, what we really see from the implementation science literature and from states and communities that have succeeded with wraparound training and support is that you really do have to have that sequence, and to not skimp on the level of support that you provide in terms of training, coaching to some level of demonstration of skill that leads to certification, and then consistent follow-on support in the form of skilled data-informed supervision throughout. And you'll see information about this if you go to the resource guide to wraparound, which I'm clicking on here on the website. You should be able to see if it ever comes up. But you'll see the section on supporting wraparound practice, and you'll see all sorts of information about how to build family partner expertise, youth partner expertise, and so forth. So we'll send that out to everybody on the webinar, and I'm going to, Ashley, just giving you advance warning, I'm going to unmute you, and you can ask anything follow-on that you like.
Yeah, that answers most of our questions. I guess what we're doing right now is we're just using the grant funding to pay some, we have a family partner organization, and then we have someone who's trained to provide the wraparound. And so we're providing that at no cost to the communities that we're funding through our grant. So if we do at some point have a training institute, typically how does the funding work as far as, is that training provided for free, or do they just have like a reduced cost to communities who want to send wraparound facilitators or family advocates to be funded, or kind of what's the norm for that?
Michelle, what do you think?
Yeah, well, I mean, I think it is, you make the decision based on how you're financing the project itself. So, for example, in our state, the initiative is really something that is state driven and funded, and so we provide the training and coaching at no cost to the vendors, to the providers who've responded to an RFP and been awarded this process, this project. So we pay for that. Now, as we move forward in healthcare reform, we're also a state that is thinking about incentive-based contracts and cost savings and other kinds of financing models. And as we shift to that, I think we put back on the table when and how training and coaching gets paid for. So if you've set contracts up with providers who are doing wraparound, and part of it is that they get to keep a amount of cost savings for that kid and family that would have gone into, a bed or residential care, then you can think about them paying into the training and coaching. But if their contract is set up in a way that they're really doing the work, they're doing the really hard work of doing good wraparound, and you don't have embedded in there some dollars for them for training and coaching or cost savings, then I think it's incumbent on kind of the state or the county entities who want to see this happen to use some of their dollars or bill for it through Medicaid or 4E, or use some of those options that they have available, because it's not really usually the provider or the wraparound folks who have the ability to kind of generate the money. So I'm kind of not giving you a you must do it this way, but you have to think about where dollars are to be organized to actually make training happen for people, and what incentivizes people to keep coming to the table. Is it a disincentive if they're paying for it because you're at that phase of development, that you're still, really kind of garnering a lot of community buy-in, and I think you make decisions based on all of those factors about funding.
Right. So how difficult is it to bill 4E or Medicaid for the training, and then who does that billing?
So I really would want to do an hour or so with you guys separately from this because it's all about documentation. So the billing isn't the issue. The issue is setting yourself up so that you're audit-proof on the back end and that you've set your processes up in a way that you're guaranteed that if 4E or Medicaid came in and audited you, you had a really robust paper trail to prove that everything you did was done and it was done the way that allowed you to bill. So it's never about the billing. You can bill and get paid for everything you bill. It's about 2 years later, you know, did you put yourself up, did you organize yourself correctly? And as long as you do that, we have states who are starting to walk down that path because of budgets and have some good experiences that could be kind of pulled together to help you guys figure out what makes the most sense, you know, to do it. But it's not about billing. You know that from just outpatient billers. Like, you can bill. The question is, can you substantiate it?
Right.
Yeah.
Okay. So is that normally done from the state level, though, or is it done from, you know, the county level or the provider level, like provider level?
Yeah, so you would have to make a decision about who was the entity that could bill for this. And so, you know, it's about, like, are you going to have a center of excellence, or are you going to have a more diffuse kind of collaborative way of doing it? And then you want to set up basically provider codes that allow just a very small group of people to actually bill for it.
Okay.
Yeah, so it's organizing that concept your state has around how you're going to train and coach people and sustain that, and then organizing with both your child welfare and your Medicaid people the way you deem that group able to bill for that, bill for training, the training codes that are within, that every state kind of has eligible for themselves for CMS and 4E. There's a bunch of steps along the way to make sure you're organized correctly to do it.
All right, thanks. I think that pretty much answers it.
That might have overwhelmed you too.
Right. It's a difficult thing, but it's well worth it when you can achieve that kind of full integration into the system, as opposed to having to rely on grant funds, or, as Michelle was describing, a single source of funds for that very essential piece of the implementation support.
Yeah, and I'm certainly willing to talk offline about options for Colorado as well. So.
All right, thanks.
Mm-hmm.
All right. Okay, so next question is an interesting one. A little bit, it's kind of in the spirit of Wraparound and integrated and collaborative care, which certainly Wraparound seeks to achieve. But it's a little bit specific here. So what suggestions do you have to integrate behavioral health into primary care? So there's an entire, line of research and health policy kind of literature on the question of integrated behavioral primary care, as well as it being a pretty huge emphasis as we move further and further into tangible types of healthcare reform in our country. I am by no means an expert on integration of behavioral health into primary care. What about you, Michelle?
Well, I wouldn't claim expertise, but I would say that probably between the two of us, we know places and documents and resources to really kind of disseminate to this group. And I guess the other thing I want to put forth is just that when you look at Medicaid data, and there's a recently published report, FACES, which I'm not going to remember the acronym for, but basically it was an analysis of the Medicaid utilization for kids in our country. And one of the things that we note is that our kids who tend to be accessing Wraparound, the kids who are multi-system involved and have some more complex needs, their cost drivers are it's always behavioral health. And so this concept of integration, I think it's really worth continuing to discuss, because families and youth tend to be more connected on the behavioral health side than they are on the primary health care side when there's pretty complex needs. And so integration, the conversation probably needs to go both ways. And I think some of the things that this group could be provided is the, I believe Sheila Pyries has recently done a FACES webinar, Eric, which would probably be very helpful to people just to get a baseline to think about not
well,
just...
Well, let's unmute Lauren real quick and just see where she's coming from with this question. Lauren, you're unmuted if you want to add any kind of context to what you are hoping to learn.
Hi. No, you've actually addressed it. Thank you very much.
Well, okay.
There
we
you
don't
go.
have to pretend to be experts on
No.
primary care integration.
No,
I mean,
but
I will
you
say
can send them out the Center for Healthcare Strategies briefs and some of those PowerPoints and white papers.
Right. I mean, I think that just kind of to sum up around this question and its relevance to NWI and the field of behavioral health for kids that's working with very complex needs, it's just like what Michelle said. The data shows that 3% of our youth are consuming 30% of our resources in Medicaid. In a lot of states, you know, looking at their budgets, the 5 to 6 to 10% of youth who are involved, who have mental health disorders, who are involved in multiple systems, are consuming 50 to 60% of our resources. And so finding ways to integrate the care they receive across systems is critical to reducing costs and improving the quality of care and outcomes. When it comes to primary care, that is a kind of very specific type of integration that isn't necessarily directed at the highest need kids and their families the way Wraparound is, but can in fact be something that's very critical in your service system to achieve. Some of the ways that I've read about in which it gets occurred is by co-locating care coordinators or case managers in primary care offices for those youth and families that are experiencing mental health, behavioral health issues that need attention, having psychopharmacology reviews conducted independently of primary care providers' prescribing practices to make sure that they're appropriate and that polypharmacy is not inappropriately being used. And then, of course, finding ways for primary care practices to co-locate or coordinate with community mental health providers. And I can send a summary of some of those strategies for integrating primary care with behavioral health in the resources we send out. Okay, next question. Any suggestions for increasing the buy-in to Wraparound for supervisors of facilitators? So when I read this, I thought this is kind of an interesting question. I'm going to guess about the genesis of this question, which is that sometimes there are provider organizations that provide a range of different kinds of services, behavioral health, mental health services, and supervisors who may be supervising a range of different types of professionals in a provider organization. They may be mental health clinicians who serve as supervisors in this provider organization and are asked to supervise wraparound facilitators, but perhaps don't necessarily have their primary orientation to providing care being the wraparound principles. And maybe they haven't even been trained as wraparound facilitators themselves before they were asked to serve as supervisors. But that's just a guess. Rebekah, I'm going to unmute you, and you can tell me exactly what is the issue or concern that you've got.
Hi, Eric. Yeah, that's pretty accurate. We do have a group of facilitators, and we're trying to implement it wraparound here in St. Louis, but we're still seeing that a lot of supervisors want to go back to what they know, which is case management, and there's a tendency, and we start seeing kind of a lot of fragmentization going on.
So, Michelle, not to put you on the spot, I think that this would be an ideal question for Marlene, who is unfortunately not able to be with us today because she has experienced this kind of, she's got a lot of experience trying to support supervisors to be good wraparound-based coaches. what is your first thought on this, and then I can try and fill in anything else you got.
Well, I mean, I think that when a group comes in and is doing the training and coaching, that it is paramount to really kind of target and support the supervisory hierarchy, not just the supervisors of the facilitators, but even if there's a clinical director or somebody above that. And so in any good kind of training and coaching model, you're really as much training and coaching them and providing resources and tools so that you can really watch their own practice evolve, so you're sure you're leaving behind some capacity at the organization when you're kind of pulling out of the training and coaching approach. So I think just focusing on facilitators hasn't gotten us as far in our implementation as we would want to see. I mean, when you look at evidence-based practice models implementing, the data and the effort really goes into supervisory capacity. And so when we don't kind of structure in that way and don't set agencies up to be understanding that we're going to hold the supervisors accountable to, we really do have significant drift happen, because it's a lot easier to go back to the business as usual. And Marlene would have multiple examples right now, but I know that in our experience over the last 15 years of implementing, we've really, not moved off of bringing skills and capacity to facilitators, but we have really organized ourselves to target supervisors, because we know that at the end of the day is going to sustain things.
Yeah, so I mean, what I would contribute is just similar to what Michelle was saying. There's the structural question, which is, are the supervisors that you are employing to actually do this critical piece of implementation support actually the right, do they actually have the right background and experience to effectively be able to embrace the wraparound principles, support others by showing them, reviewing their materials and their data, and reflecting accurately on whether or not this represents good wraparound practice or not. And so, from the outset, the ideal, because it is so critical, is to have your supervisors be folks who have themselves come up through that workforce development ladder, from in-depth training on wraparound, mentored practice towards some sort of skill-based capacity. And then I've got up here on the screen a number of articles that are on the National Wraparound Initiative website. Again, if you go to resources on any of these topics and click Resource Library, you will get this search box, and just putting in supervision shows you a range of different kinds of resources, an array of different resources that may be helpful to thinking about, regardless of whether or not you have the ideal supervisors or not. What would be some ways that some real experts in the field like Pat Miles and Debbie Manners, what are some methods through which wraparound supervision and management can be structured or supported? One of the ways in which we think that supervision can be structured to be more effective is to, in fact, use data that is collected on the level of demonstrated skill of the practitioner, the facilitator, or whoever, as the way of structuring the supervision that's provided. So the supervisor, again, regardless of their background, could be instructed or trained to, in fact, be talking to families about what they experienced in the wraparound that they got from this staff, looking at plans of care, observing wraparound practice, and using structured measures on a periodic basis to be able to provide that feedback, so that it's not the crisis of the week kind of supervision that often occurs in any kind of practice setting, but is really specific to whether or not this practitioner is demonstrating the skills that are necessary to get good outcomes. So if you go to the website, you'll see examples of handbooks around directive supervision, an overview of supervision and management, and some how-tos. But in in response to your basic question, which is how do you get buy-in around wraparound, that's a trickier one, and it's kind of a systems question more than a practice question, because it really does, as Michelle was saying, beg the question, is your system or your organization truly structured to embrace that kind of approach to bringing up folks who understand the skills and embrace the principles, and then have them be the ones who are installed in coaching or supervision positions. That's the ideal. Rebekah, I'm unmuting you because I know that that's kind of not an easy, it's a tough question and not an easy answer to be able to provide you.
Well, that's helpful, and those resources look like they could point us in the right direction, so thank you.
Right. So I think the bottom line is structurally you want to have those supervisors who are selected who can truly speak from experience and also who live the principles. But regardless of who they are, we want to respect the importance of the supervisory role in high-quality practice and make sure that the work that they do is structured and data-informed. Anything else, Michelle?
No, I just think that it's I think because of the roots of wraparound that we don't take always as seriously the implementation science that we know to be important to success. And so, my example earlier of evidence-based models where you've got a purveyor out there kind of forcing you to do it in a certain way, with wraparound we've had more flexibility and latitude, and yet we've not always been as successful because we kind of shortchange some really important aspects of implementation. Supervision being, the supervisor being one of those really important aspects for success.
So Rebekah has a few questions here. Rebekah, I'm going to unmute you and let you, so we can get to other folks as well. What's the most important of the remaining questions that you have? What's the one you really want to get to, and if we have time, we'll get to your other ones.
Let's see. I think any tips on minimizing or streamlining documentation so we're meeting accreditation standards like JACO or CARP?
I think I'm going to have to defer to Michelle on that one.
Well, Eric, I thought you'd want to talk about RAP TMS here a bit, because that is how our state intends to kind of move forward with CARF in particular. Mm-hmm. Do you want to do that?
Well, you're going to have to help connect the dots around the way in which you can use the data system to meet those standards. But I can describe that there is a webinar on our electronic behavioral health information system that we're developing that's specific to wraparound, that is intended to help manage the process, including maintain all of the necessary documentation in one electronic health record IT system that is nonetheless specific to the wraparound process. So whereas typical health information systems will have a minimum kind of data set around diagnosis and provider information, perhaps billing, progress notes, crisis incidents, and so forth, what our wraparound team monitoring system, or RAP TMS, that we are developing and now making available to the field also allows is electronic maintenance and sharing among team members of things like the CANS assessment, or the Child and Adolescent Needs and Strengths Assessment for the child, the strengths, needs, culture information that emerges from the engagement phase of wraparound, a plan of care that includes specific needs, priority needs linked to the treatment strategies, and where appropriate, the clinical services that have been approved. So our intent in creating this was to provide the field that's increasing of integrated behavioral health care models like wraparound, a system that's more designed to kind of be that one health record and IT system that can maintain all of those, and through a permission-driven approach, allow all members of the team to view the plan of care, for instance, in advance of a meeting, in advance of a therapy session. If you are a member of the team and have permission, you'll have access to all of that. It also builds in progress monitoring and outcomes monitoring and satisfaction measurement for systems that want to use the IT system to do that. So again, the intent here is to streamline the process, reinforce fidelity to the model by making it all wraparound relevant, while also meeting some of those IT needs and those documentation needs that any provider organization has that's doing behavioral health. So with that, I turn it to Michelle, who can explain how that actually streamlines documentation and facilitate accreditation.
But Rebekah, did that help at all?
Yeah, I mean, I was here for the webinar on TMS, and it is a great-looking system. But right now we are taking a hard look at our wraparound forms and making sure they're hitting the JCO standards and CARF standards.
Yeah, and so, I mean, as we've been kind of contributing to helping build RAP TMS, the reason I had Eric say that was because we've been doing the same crosswalk, because Maryland is also a state that is using accreditation in lieu of licensure in some situations as we move forward. So that system has been kind of crosswalked against those standards as well. But I don't know that I have any better advice for you than that. You know, obviously the only way the IT system Eric described helps is that it's web-based, it's all in one place, and it's kind of standardized. But it is onerous, and, you know, more power to you as you're kind of crosswalking it. It's just a difficult job to keep up with accreditation standards and yet make it not onerous for our staff. I don't think I have anything smarter than that to contribute.
It is challenging because it is a lot of the accreditation goes back to the medical model, whereas we don't always look for those things.
Yep, absolutely. And so CARF, I heard you mention CARF. I mean, CARF obviously moves us a little closer than JCO towards kind of community-based models, but it still is difficult right now the way the accreditation bodies are working. Now, CARF is actually working on a health home accreditation, and so I do think because of some of the things that are happening in the field right now that these accreditation bodies will continue to evolve, but that doesn't help you in 2013 necessarily.
And Rebekah, just really quick around your last question, because I do think I can answer this pretty quickly. Data regarding wraparound's effectiveness and working with children under 5. There are a few real kind of adventuresome, innovative programs out there that are using the wraparound model for younger kids explicitly and their parents, typically. You know, a lot of these are kids who are involved in the child welfare system. The answer to your question, the brief answer to your question is no, there's not any real rigorous studies out there that demonstrates any kind of differential effectiveness, you know, either that it's less effective or more effective or equally effective for young children. We don't necessarily think that there's any evidence that's or theory that suggests that it shouldn't be. Part of wraparound's intent is to be individualized to meet the needs of any family that is being served in the system. And because it takes this kind of individualized, holistic, family-driven approach, needs are defined you know, regardless of the type of diagnosis or problem area that the family might have or that the child might have. So we don't really necessarily think that it is any less effective. However, the details and logistics of working with families who have younger kids is certainly not insubstantial. So what I can do is to send you to a couple of the places that are doing quite a bit of work with kids under 5. The 2 sites that I'm going to suggest are one in Colorado where a colleague of mine has been working with a very early intervention wraparound program in a pediatric setting. And the second is one in Connecticut where there actually is a study going on evaluating whether or not wraparound style interventions for young children in the child welfare system who also, whose parents or themselves have behavioral health needs, is getting better child welfare outcomes than business as usual. But those folks may be able to give you information about the specific adaptations that they have you know, recognized they needed to make with wraparound in order to serve that younger population. So I'll send you both to Christian Connell in Connecticut and to I'm blanking on his name, but my friend in Colorado who's doing the young kid wraparound there. Okay?
Thank you.
Absolutely. So moving down the list here, not seeing any hands up, so I'm just going to keep it going down the list of written questions. One thing is that Frank Lilausa has got some information for folks in Colorado for training. So maybe, Frank, if you just put your email into the question box, folks who are on the line will, from Colorado who had that question might be able to write you and get those contacts. Certainly Colorado's got a lot of fantastic trainers. That's where Vroon Vandenberg obviously is located, as well as Lori Beckel, who has been recognized as an outstanding trainer and used by a lot of states. But if you have others, maybe you can contact Frank. Next question is, can you describe some of the challenges you've come across in serving higher risk probation-involved youth? What are some strategies for locating community resources and adult supports if their families are difficult to engage? So, Michelle, maybe I'll go to you first, and I'll think about this as well. Do you have any kind of first experiences from Maryland about how you, as you've built your care management entity, statewide system, attempted to build the resources for that particular sector of youth that might be enrolled in Wraparound?
Well, I feel like we've had a lot of lessons learned along the way, and our so Maryland was a PRTF demonstration waiver site, and in our kind of final iteration of learning, we're implementing through Medicaid a 1915I, and so it's within that submission of a new state plan amendment that we really added a different level of community-based services and funding, and added in the capacity for some more home and community-based evidence-based models, and that is really specifically targeted at our older child welfare and juvenile services kids that access this approach in Maryland. And so I can certainly forward some of the service descriptions and some of the ways that we've kind of organized and financed, and then obviously the issue of engagement and readiness is always an issue. I don't know if that really gets to the heart of what Emily is asking, but we had to literally go out and reorganize how we were able to fund some things to really make it, our providers capable of bringing up services that could meet the needs in the community of the kids, within a wraparound context.
Yeah, and I think that one of the things, there is an article on the website, if you're a member, that talks about Wraparound Santa Cruz's experience working with youth on probation. One thing that comes to my mind is that when you're talking about a specific kind of segment of the at-risk youth population or youth with complex needs in your community, such as kids who have been offending, who are on probation, Wraparound is one thing that you can say is that Wraparound, it's important to make sure that you have an array of services and treatments in your community that can be accessed through the Wraparound process. And you refer to that in terms of strategies for locating community resources and adult supports. It's kind of a basic tenet of Wraparound that you need something to actually wrap around most families and youth that you're working with. There are some families and youth who will benefit simply from the process of having a team come together to define to kind of explore your strengths, reframe the kinds of issues that the youth or family might be having, prioritize the needs, come up with strategies. But very often what's really critical is that those priority needs, once kind of identified, can be linked up with effective strategies and services. So when you're talking about probation youth, you got to be asking, you know, does your community have the capacity in its provider array to invest in some of the evidence-based interventions for this population? And you just can't get away from the fact that interventions such as multisystemic therapy, functional family therapy have an extraordinary track record. Because they're brief and intensive, they may not meet all the needs of a family enrolled in Wraparound. And a Wraparound enrolled youth ideally will have access to these kinds of evidence-based interventions, and if necessary can transition back to more formal Wraparound to ensure that other family and youth needs are met. Similarly, at the beginning of the process, if it seems to be a good fit for the family and the youth would be eligible for such a program, the Wraparound process can be a way to ensure that the family is understanding what being referred to one of these programs might be, and make sure that it's a successful engagement in that intensive evidence-based treatment. It's kind of like Pat Miles says, if you know what to do, do it. If you don't know what to do Wraparound. And so if you know
and
that
sometimes both.
Right, exactly. You can do both. You can have Wraparound and know that there is a logic to enrolling a youth and their family in one of these intensive programs.
Mm-hmm.
So again, you know, my point is that if you are serving a large number of high-risk probation-involved youth, quote unquote, then you need to be asking, you know, not just how can Wraparound serve those youth, but how is your overall array of services and supports set up for serving those youth. And that's one of those kind of higher level functions that has to occur in a community that is implementing Wraparound, is to have a team of decision makers and families that are asking questions about who are you serving, who are you spending the most money on, what could you invest in the community to make sure that Wraparound teams have access to the resources that are going to be most needed, and sometimes, you know, what are the evidence-based treatments you need to have available for youths regardless of whether they're enrolled in Wraparound and access it through Wraparound.
I also think we have some emerging efforts. There's an organization called Open Table in our nation now that's really trying to organize churches around poverty issues. And they've started tackling the idea of how many of our kids in child welfare are leaving our systems homeless or really not resourced. And so we're really kind of working with Open Table on, particularly in our rural communities in Maryland, to have them support efforts around particular life domains and particular strategies that provide a lot of stabilization for families. And I think there's a lot of opportunity for us. There's kind of, I guess from the Maryland perspective, there's Wraparound as a model that we know that works and we need to invest in it as an evidence-based approach. There's ensuring our service array has as many evidence-based or evidence-informed models as possible. And then there's the idea of really better engaging churches and community resources to engage these issues, you know, engage for families around poverty and other major systemic issues, and kind of reaching both ways. It just all has to be done simultaneously to really connect with many of the families that are engaged in WRAP.
So I'm unmuting Emily. She had a follow-on question, I think, which was, let's see, where was it here? Did you have to do new trainings to those providers? So Emily, why don't just, because this is a really, you know, big question and an important nut for any community or state to crack, which is, you know, how do you make sure that your capacity to provide an array of services is adequate? Why don't you just talk a little bit about what you're trying to do, and where are you from, first off? Emily, are you able to, maybe you don't have a mic. So I'm going to assume Emily.
She has a note that says
I have no mic. Sorry, Emily. Sorry about that. Well, her follow-on question is, do you need to have new trainings to those providers, or do you have to do new? I'm not sure exactly what she's saying, but I think you know, the answer is that for providers in a service array that you want to bring up to be able to provide these kind of focused evidence-based practices, there are a lot of expectations around the training and certification of individuals who would be trained to do these EVPs, to be sure.
Agreed.
Around the big question, you might want to go to the NWI website within the resource library, or I'm sorry, the resource guide. You will see some articles about how to set up a community team to kind of be evaluating the needs of your community based on the characteristics of the youth and families, and how to try and kind of set up your service array. You can also see some of this stuff by going to the implementation support section of the NWI webpage, and I'm showing it here. You can go to community partnership, and it will describe some of the structures that you can strive to put in place to oversee the development of your service array and develop some of those community resources and connections to community resources that your different youth and families might need. All right, we've got a few questions left here. I'm looking at a number of questions from Jody Roberts. She's got a few, so I'm going to say, Jody, let's see, you can't be unmuted until you enter your PIN. So maybe we'll just pick a couple of your questions here. Are peer support functions typically met by the Wraparound agency or a separate family support organization? I'm going to turn that to Michelle real quick and show a few resources that we have on that topic.
So across the nation, we do it in a lot of different ways. That's the short answer. So Massachusetts has implemented statewide with family support, family peer-to-peer support people working within the entities that are doing Wraparound, and they're partnered with Wraparound facilitators. In Maryland, we do it separately, and you can kind of go through the nation and see how everyone has done it a little bit differently. I think the emerging trend is to have it outside of WRAP organizations, but I wouldn't, having experienced training and coaching in Massachusetts, say that you can't, that it has to be one way or another. Eric's got a bunch of resources up for you right now. There's pros and cons to all implementation, and I think you have to, reading some of these materials and thinking through the context that you live in your state or your community, you make the kind of decisions in those ways. I do think that over the last 10 years, many of our statewide family network organizations and other family organizations in states have really taken on the issue of implementing Wraparound. And so I personally think that there's also there's a real advantage to using those organizations to do peer-to-peer support, and because it not only does it provide that function within Wraparound, but it also provides some actual support to our family organizations around the nation, which is really an important component of our systems of care. But I think Massachusetts, as an example, has done an excellent job, and their peer-to-peer support partners are embedded. So, Eric?
Right. Yeah, so this is something that a lot of folks ask, and there has been a lot of materials generated by the NWI or on behalf of the NWI by folks like Pat Miles. You can see in the resource guide to Wraparound, there's an entire section on Wraparound practice that's specific to questions about how to deliver family support and how to structure it. And the one that I was just looking at is this one by Pat Miles, Family Partners in the Wraparound Process. She provides this table of different options for how you embed capacity to do family-to-family peer support. So whether, options such as having a paired facilitator plus family partner team, as in Massachusetts, having peer-parent support available but not mandated for every family, parents as peer interveners, parents as system developers or family involvement coordinators. So you'll see a whole bunch of articles on this topic that I think are pretty kind of fundamental about decisions that face wraparound initiatives across the country, and I encourage you to go check those out. We will provide that in the little resource list that we prepare for the webinar attendees, and links to all of these. But all you got to do is go to the Wraparound NWI website and search for family partner articles, and you'll find a whole bunch of these. So one other question from Jody, since this is kind of relevant to the previous discussion about MST and FFT. In Louisiana, families are not allowed to access MST or FFT while they're in wraparound because of concerns about duplicative services. Is this common around the nation? Unfortunately, I do believe it is. Michelle, why is this such a common problem?
Well, I mean, I think we have a history of seeing wraparound in some ways in competition with EBPs, so I think there's a little bit of kind of old philosophy that goes with this. And then I think those kind of people that do number crunching get worried about having, you know, this level of expensive service. You can kind of answer the question depending on the role you play in the system. I also think that we have had a period where EBPs like MST have, within the model itself, there's the clinician is the lead, and so there's a level of detail you have to work out in a local community when you have a wraparound family who's experiencing a child and family team and you have an MST therapist. Like, that's just truth. But we've seen that worked out in a number of places, California and other places. I mentioned earlier that we wrote into our new state plan amendment a number of EBPs, and FFT was a primary EBP that we put in to be part of the service array for wraparound. So I think it is, I think you have to, you know, sit back and look at the population of kids and families that you're expecting to be served in wraparound. And obviously, you know, any state agency is going to also look at the numbers, but I think we have to move past a little bit some of the idea that wraparound doesn't need that service array of pretty robust EBPs. I think it's a needed service. I think sometimes we shortchange the clinical services that need to be available for families to be really successful. So that's my soapbox.
Yep, absolutely. And we are, you know, not to always just be providing answers that relate to resources that we've developed, but these are the things that I know the best. There is a webinar on the NWI website that was recorded about the issue of clinical care and evidence-based practices, coordinating them with wraparound. And so if you're interested in this topic overall, and one approach that wouldn't demand that you have intensive services administered at the same time as wraparound, you can look at this webinar called Coordinating Evidence-Based Practices with Wraparound Using the Managing and Adapting Practice System. And this idea is based on the notion that evidence-based practices really are, at their essence, just different configurations of a fairly manageable number of common practice elements of effective therapies that could be individualized to meet needs in the wraparound process. So an alternative to using something intensive and packaged like MST or FFT would be to have clinicians in your system trained on how to flexibly apply the different common elements of evidence-based practice in a way that meets the identified needs of the youth that's enrolled in wraparound. And in this way, the clinician in your wraparound system would be using more effective practices in their clinical care, which we would think would get to better outcomes, but also it would mean that they would be able to be better team members because they would be able to explain exactly what kind of strategies they're using in the work they're doing with the youth and the family and how it matches up with needs. So there's different ways to get at this issue, which is very critical, as Michelle said, that you have to have good clinical services available in your service array or in your community when you're doing wraparound, because we don't want to have a donut hole that wraparound is trying to wrap around nothing, so to speak. All right, so we are getting close to the end of our questions. Alicia had a follow-up question. Can I please get some of the information to engage or reach out to community members of the high-risk probation youth as well, from Michelle? Alicia, I don't want to put you on the spot, but I'm going to unmute you because it sounds like you've got a need for some specific information or resource. If you're still there, you can kind of let us know what you're looking for. Alicia, are you there?
I think Alicia wants the definitions, and so I mentioned that we could release kind of the service definitions that we use, one being for FFT, like I just mentioned. I think that's what she wants.
Okay. Can you make sure you get me that as I put this stuff together, Michelle? Okay.
And I see no mic, so I think she has no mic.
Okay.
Yeah.
Just giving it a shot here. We're making the road by walking today. One of my favorite expressions. Let's see, is there any other questions? RAP looks very different. This is from Frank. RAP looks very different in many communities due to various reasons. We have weak teams due to few systems involved or minimal natural supports. People move to our mountains to avoid people. We do RAP the best we can as adhering to the principles and phases. I think these are important, and what is our uniqueness? It is frustrating that sometimes we feel more like family preservation instead of wraparound. Well, that's a pretty insightful observation, that in the absence of that kind of array of community supports, community organizations, providers who can meet a range of needs, it can really feel like a facilitator out on an island struggling to actually meet the needs of families just by themselves. And that is something that is, I mean, it's kind of a bigger problem than just how do you make wraparound effective, which is around the scarcity of resources in certain of our rural and frontier areas. I don't know, Michelle, if you've seen any effective or strategic ways to deal with that phenomenon in those kinds of settings.
I feel like my RAP trainers and coaches are much closer to the ground on these kind of things. I will mention again, though, that for our rural areas in Maryland, one of the groups we've partnered with is Open Tables, which is really a church movement, and it's non-denominational. It's got cutting across the denominations in the country, and they have been a great partner, and it just kind of brings this other element, this other organized element to the table around many life domain issues that we struggle with when there aren't team members on the team, particularly, jobs, poverty, those kind of things. That's what Open Tables organizing of churches has been most helpful about. And so we can send out some of those resources because I think it's a newer connection with wraparound. We're seeing John Vanderberg and ourselves really kind of try and figure out some ways to work collaboratively with the leadership at Open Tables. And they're both in urban environments, but there's been some real successes already in our more rural communities. Just bringing a different group of people to the table to be resources for families that are really in need.
So Frank, I've unmuted you. It looks like Jane may have some ideas here, but I thought I'd just go back to you, Frank, to see if you'd ever heard of Open Table or if there's anything that you've found to be even a little bit helpful in your quest.
I don't know, can you hear me?
I can.
Okay. In the small community here, we actually do have some pretty good community partners, and we're constantly looking for those. So that isn't too bad, but just sometimes lack of systems. We'll get a referral, and then people close out. So there's not a lot to work with us besides us and the families, and then usually the schools, and that's fine because we don't have big teams, so that can make things easier, but it does get kind of frustrating that we don't get into the real meat of some of these hardcore cases that I think we could do well with. And I've never heard of the open table, and we have engaged some of our churches that have a lot of resources, firewood or just money for rent, that type of thing. So I think we're doing pretty good community-wide, and you guys hit on some things that kind of sound like what we're already trying to do. So I appreciate that.
That's great.
Yeah, it's a tough nut to crack, to be sure, in those kind of communities. It sounds to me some places would be thrilled not to have too many systems involved in their wraparound and to only have to deal with, or only have to engage their churches and, you know, informal supports, retirees who are interested in giving back, young people who want to be mentors. For a lot of our wraparound agencies out there, I think that would be a dream, would be to not have to deal with systems if they were able to be funded to do that kind of work. Jane, I'm going to unmute you because you have your hand up. What's on your mind? Do you have something for Frank or something new to talk about? Maybe Jane didn't mean to have her hand up. Jane Rood, are you out there? Okay, I'm going to go ahead and mute you back again. So we have, we've got one last question. I think that Jody has got another one here. Jody Jody has no mic. We are a newly implementing system of care in Louisiana. Can you tell us more about how transition planning is done and documented through the wraparound process? So unfortunately, this would be one that would be much better for Marlene and Joanne because they live the training and support around the practice model every day, much more so than myself. I think that, you know, we know what some of the ideal kinds of steps in the transition phase are for wraparound that you're hopefully getting trained on perhaps by the Institute if you're in Louisiana. Isn't that right, Michelle? If they're in Louisiana, are they getting trained by you?
They are, correct.
So I can only really say at this point that I'm hoping that this is a kind of support that you and your staff are getting. That said, we can go to, and just for everybody's purposes here, if you go to, you know, the phases and activities of wraparound, you can kind of be reminded of what some of the basics are about the transition phase of wraparound. We know that our hope is to that the transition occurs when not at some sort of pre-designated time point, such as you know, the expiration of your eligibility to receive services, but rather when needs have been met, the priority needs that the family identified have been met, or substantial progress has been made towards them, such that we can transition out of formal wraparound. And as the phases and activities of the wraparound process, you know, document talks about, transition is something that ideally you focus on throughout the wraparound process because you are, in fact, from the outset identifying the vision for the family. And as needs are being met and the vision for the family the family is closer to their vision for the future than they were at the beginning of the wraparound process, this is when you know that transition out of formal wraparound and into a mix of formal and natural supports in the community is something that you're ready to do. So, you know, as described here, and these would be some of the things that you and your staff will get trained on. There's the planning for transition out of formal wraparound that occurs, so creating a transition plan, creating a post-transition crisis management plan. So you're talking about what kind of documentation you need. The transition plan is critical. That post-transition crisis management plan is critical. You very well may, in fact, even practice or do some role plays around how some of those potential crises that might arise in the future would be responded to by formal and natural supports that the family will have available to them even out of formal wraparound. Documenting the team's work in terms of creating something that describes the strengths of the youth and family and team, lessons that were learned, again, preparing for potential crises. These are documents that should be something that is created at the end of wraparound so that you have this package of information that the family can use as they access resources in the future, and also for their own recognition of the successes that they experienced during the wraparound process. And then finally, there's something kind of important that you systematically build into your system of care or your wraparound initiative, which is that you are in fact following up with the family, creating some sort of procedure as you exit formal wraparound for checking in with the youth and family after commencement or the end of formal wraparound. This could be done through questionnaires, email, through periodic phone calls, etc. So there's a few types of documents that are kind of critical to create, but this is the ideal, and the question becomes, how do you actually achieve this consistently? And that's what real intensive and effective training and coaching, as we know you're getting from the Institute, can help make sure that happens. Michelle, you got anything else? We seem to be at the end of our questions.
I feel like you covered it.
Yeah. So, Jody, if you have anything else on that, type it in quickly. But as for now, I think we're going to go ahead and wrap up. I've got a list of different resources and materials for questions involving youth partners, training and support for facilitators and family advocates, integration of behavioral health and primary care, supervision, early intervention or wraparound for families with young children, higher risk probation youth, family support models, and rural and frontier options such as open table. And what I'm going to do is kind of put together links to the different resources or attach them and send them to the specific folks who asked for these things. But as best as I can, we'll include all of these resources for everybody that was on the webinar, because we recognize that you all might be interested in seeing them now. Yep, no more questions. So with that, Michelle, thank you for being here with me today. We missed having Marlene and Joanne with us. Because this is a really new thing that we've never done before, even recognizing we didn't have our full array of experts, it would be great if once you're done, you're going to get a survey, a link to a survey about whether this was helpful and the level of quality and helpfulness that this provided for you. Please give us any feedback that you can so we know whether to keep doing this in the future and how we could improve it. Anything else from you there in Baltimore? Okay, thanks everybody, and feel free also to send any follow-up questions to NWI@pdx.edu. Let me go to our little closing screen here. Send us an email if you want any more information or have any follow-up questions. And take care.
Thank you. Bye.
Bye-bye.
Can you guys hear me?
I can, but I have to figure out how to stop recording or